Welcome to Nurse's Lab.
You're about to enter the world of advanced cardiovascular life support, where every decision counts, every second matters, and every action can change the outcome. This is not just a test. This is preparation for the moments when the room goes silent, the monitor alarms, and all eyes turn to you. In the next series of questions, you'll face the same scenarios that challenge real clinicians: shockable rhythms, pulseless arrests, airway dilemmas, medication timing, and the critical steps that separate hesitation from mastery. Treat each question as if a patient's life depends on it, because in practice, it will. Stay focused, think systematically, follow the algorithm, and remember, ACLS isn't about memorizing steps. It's about understanding the physiology behind every move you make. Let's begin your ACLS practice test. Take a breath and step into the questions. Question number 1. A 58-year-old man collapses in the ICU. He is pulseless. Monitor shows ventricular fibrillation. High-quality CPR is started and oxygen is attached. What is the next best action? A. Give epinephrine 1 mg IV immediately. B. Deliver a shock. C. Insert advanced airway first. D. Give amiodarone 300 mg IV. Correct answer, B. Deliver a shock. So what about its explanation? In the 2025 AHA Adult Cardiac Arrest algorithm, VF/PVT is treated first with defibrillation plus CPR. Epinephrine comes later during subsequent CPR cycles, and amiodarone/lidocaine is considered after additional shocks for refractory VF/PVT. Question number 2. A patient is in PEA arrest. CPR is in progress. IV access is available, and reversible causes are being considered. Which medication should be given first according to the AHA 2025 algorithm? A. Amiodarone 300 mg IV. B. Adenosine 6 mg IV. C. Epinephrine 1 mg IV/IO as soon as possible. D. Atropine 1 mg IV. Correct answer, C. Epinephrine 1 mg IV/IO as soon as possible. Now let's see its explanation. For asystole/PEA, the 2025 AHA Adult Cardiac Arrest algorithm says to give epinephrine ASAP, then continue CPR in 2-minute cycles while treating reversible causes. Question number 3. During ACLS for cardiac arrest, how often should epinephrine be administered? A. Every 1 minute. B. Every 2 minutes. C. Every 3 to 5 minutes. D. Every 10 minutes. Correct answer, C. Every 3 to 5 minutes. Now let's see its explanation. The 2025 AHA Adult Cardiac Arrest algorithm lists epinephrine 1 mg IV/IO every 3 to 5 minutes during arrest management. Question number 4. A patient remains in pulseless VT after multiple shocks and CPR. Which medication is appropriate next? A. Atropine. B. Amiodarone or lidocaine. C. Adenosine. D. Verapamil. Correct answer, B. Amiodarone or lidocaine. So let's see its explanation. For shock refractory VF/PVT, the 2025 AHA algorithm recommends considering amiodarone or lidocaine. Routine atropine, adenosine, and verapamil are not indicated here. Question number 5. You are using a biphasic defibrillator for adult VF, but the manufacturer's recommended initial energy dose is unknown. What should you do? A. Use 50 joules. B. Use 100 joules. C. Use 200 joules only. D. Use the maximum available energy. Correct answer, D. Use the maximum available energy. So let's see its explanation. The 2025 AHA algorithm states that for biphasic defibrillation, use the manufacturer's recommendation. If unknown, use the maximum available. Question number 6. A patient in cardiac arrest has an advanced airway placed successfully. What is the correct ventilation strategy? A. 30 compressions to 2 breaths. B. 1 breath every 3 seconds. C. 1 breath every 6 seconds with continuous compressions. D. 2 breaths every minute. Correct answer, C. 1 breath every 6 seconds with continuous compressions. So let's see its explanation. Once an advanced airway is in place, the 2025 AHA algorithm recommends continuous chest compressions with 1 breath every 6 seconds, 10 per minute. Question number 7. A 67-year-old patient has a heart rate of 180 per minute with hypotension and acute altered mental status. The rhythm is regular narrow complex tachycardia. What is the best next step? A. Observe only. B. Vagal maneuvers only. C. Synchronized cardioversion. D. Procainamide infusion. Correct answer, C. Synchronized cardioversion. Now let's see its explanation. In the 2025 adult tachyarrhythmia algorithm, persistent tachyarrhythmia causing hypotension, altered mental status, shock, ischemic chest discomfort, or acute heart failure requires synchronized cardioversion. Adenosine may be considered for regular narrow complex rhythms, but instability makes cardioversion the priority. Question number 8. A hemodynamically stable patient has a regular narrow complex SVT. What is the most appropriate first-line treatment sequence? A. Defibrillation, then amiodarone. B. Vagal maneuvers, then adenosine if needed. C. Atropine, then pacing. D. Immediate unsynchronized shock. Correct answer, B. Vagal maneuvers, then adenosine if needed. So what about its explanation? For stable narrow complex tachyarrhythmia, the 2025 AHA algorithm recommends vagal maneuvers if regular, then adenosine if regular. Question number 9. A patient has a heart rate of 34 per minute, BP 76/40 mm Hg, diaphoresis, and confusion. What is the recommended first drug? A. Adenosine 6 mg IV. B. Atropine 1 mg IV bolus. C. Epinephrine 1 mg IV push. Or D. Amiodarone 150 mg IV. Correct answer, B. Atropine 1 mg IV bolus. Let's see its explanation. In the 2025 adult bradycardia algorithm, symptomatic bradycardia with cardiopulmonary compromise is treated first with atropine 1 mg IV. Repeat every 3 to 5 minutes to a maximum total dose of 3 mg. If ineffective, consider transcutaneous pacing, dopamine infusion, or epinephrine infusion. Question number 10. During standard adult cardiac arrest care, a team member suggests giving routine sodium bicarbonate and calcium to improve outcomes. What is the best response? A. Give both routinely in all arrests. B. Give magnesium instead of both. C. Routine calcium and sodium bicarbonate are not recommended in standard adult cardiac arrest. D. Give calcium only in VF. Correct answer, C. Routine calcium and sodium bicarbonate are not recommended in standard adult cardiac arrest. Now let's see its explanation. In the 2025 Adult Advanced Life Support Guideline, it states that routine administration of calcium and sodium bicarbonate is not recommended in standard adult cardiac arrest. These may be considered in special circumstances, such as suspected hyperkalemia or certain toxicologic causes, but not routinely. Question number 11. A patient is in pulseless ventricular tachycardia. You deliver the first shock. What should you do immediately next? A. Check the pulse. B. Resume CPR for 2 minutes. C. Give epinephrine 1 mg IV. D. Insert an advanced airway. Correct answer, B. Resume CPR for 2 minutes. Let's see its explanation. In the adult cardiac arrest algorithm, after a shock for VF/PVT, the team should immediately resume CPR for 2 minutes before the next rhythm check. Pulse checks are not done right after the shock unless an organized rhythm with signs of circulation appears later in the cycle. Question number 12. A patient remains in VF despite shocks, CPR, epinephrine, and a first dose of amiodarone 300 mg IV/IO. What is the recommended second amiodarone dose? A. 75 mg IV/IO. B. 100 mg IV/IO. C. 150 mg IV/IO. D. 300 mg IV/IO. Correct answer, C. 150 mg IV/IO. Now let's see its explanation. The 2025 Adult Cardiac Arrest Algorithm lists amiodarone 300 mg IV/IO first dose, followed by 150 mg IV/IO second dose for refractory VF/PVT. Question number 13. A 72-year-old patient has symptomatic bradycardia with chest discomfort and hypotension. Atropine has been given appropriately, but the patient remains unstable. What is the best next management? A. Adenosine rapid IV push. B. Synchronized cardioversion. C. Transcutaneous pacing. D. Defibrillation. Correct answer, C. Transcutaneous pacing. So what about its explanation? For persistent symptomatic bradycardia after atropine, the 2025 AHA bradycardia algorithm recommends transcutaneous pacing and/or dopamine infusion or epinephrine infusion, depending on the clinical situation. In an unstable patient, pacing is a key next step. Question number 14. Which of the following is the recommended epinephrine infusion dose for symptomatic bradycardia when atropine is ineffective? A. 1 mg every 3 to 5 minutes. B. 2 to 10 micrograms per minute infusion. C. 20 to 40 micrograms per minute infusion. D. 0.1 milligrams per kilogram per minute. Correct answer, B. 2 to 10 micrograms per minute infusion. Now let's see its explanation. In the adult bradycardia algorithm, the recommended epinephrine infusion range is 2 to 10 micrograms per minute, titrated to patient response. Question number 15. A conscious patient with a pulse has stable monomorphic wide complex tachycardia. Which treatment is appropriate? A. Immediate defibrillation. B. Atropine 1 mg IV. C. Antiarrhythmic infusion such as procainamide, amiodarone, or sotalol. D. Epinephrine 1 mg IV. Correct answer, C. Antiarrhythmic infusion such as procainamide, amiodarone, or sotalol. So, what about its explanation? For stable wide QRS tachycardia, the 2025 tachyarrhythmia algorithm recommends considering antiarrhythmic infusion such as procainamide, amiodarone, or sotalol, while expert consultation may also be appropriate. Question number 16. A stable patient presents with a regular narrow complex tachycardia at 180 per minute. Vagal maneuvers fail. What medication is recommended next? A. Adenosine. B. Atropine. C. Lidocaine. D. Magnesium sulfate. Correct answer, A. Adenosine. Now, let's see its explanation. For stable, regular, narrow, complex tachycardia, the 2025 AHA tachyarrhythmia algorithm recommends adenosine after vagal maneuvers if the rhythm remains regular. Question number 17. During adult cardiac arrest without an advanced airway, what compression to ventilation ratio should be used? A. 15 to 2. B. 30 to 2. C. Continuous compressions with one breath every 6 seconds. D. 10 to 1. Correct answer, B. 30 to 2. Let's see its explanation. In adult cardiac arrest, before an advanced airway is placed, standard ACLS BLS care uses 30 compressions to 2 breaths. Once an advanced airway is in place, compressions become continuous with one breath every 6 seconds. Question number 18. A patient remains in PEA arrest despite ongoing CPR and epinephrine. The team leader asked the team to evaluate reversible causes. Which action is most appropriate? A. Stop CPR to complete a full 12-lead ECG. B. Search and treat H's and T's. C. Give adenosine 6 mg IV. D. Delay interventions until ROSC occurs. Correct answer? B. Search and treat H's and T's. Explanation: in PEA asystole, ongoing management includes high-quality CPR, epinephrine, and systematic evaluation for reversible causes, H's and T's. Question number 19. You are about to cardiovert an unstable tachyarrhythmia, but the exact device-specific recommended energy setting is not known. According to the 2025 AHA tachyarrhythmia algorithm, what should be done? A. Cancel cardioversion. B. Use the maximum available energy if the device recommendation is unknown. C. Use only 50 joules for all rhythms. D. Give atropine first. Correct answer is B. Use the maximum available energy if the device recommendation is unknown. So let's see its explanation. The 2025 Adult Tachyarrhythmia algorithm notes that providers should use the device-specific recommended energy to maximize first shock success, and if not known, use the maximum available energy. Question number 20. Which medication strategy is not recommended routinely in standard undifferentiated adult cardiac arrest unless there is a specific indication? A. Epinephrine. B. Amiodarone for refractory VF or PVT. C. Routine sodium bicarbonate, calcium, magnesium, or steroids. D. Oxygen and high-quality CPR. Correct answer is C. Routine sodium bicarbonate, calcium, magnesium, or steroids. Now, let's see its explanation. The 2025 Adult Advanced Life Support Guidance states that these medications should not be given routinely in undifferentiated adult cardiac arrest. They may be appropriate only for Question number 21. A 64-year-old man collapses in the cath lab. He is pulseless and the monitor shows VF. High-quality CPR is started and he receives a shock. After the next rhythm check, he remains in VF and is shocked again. IV access is established. What is the most appropriate medication next? A. Adenosine 6 mg IV push. B. Epinephrine 1 mg IV IO. C. Atropine 1 mg IV. D. Magnesium sulfate routine bolus for all VF. Correct answer, B. Epinephrine 1 mg IV IO. So let's see its explanation. In the adult VF PVT arrest algorithm, epinephrine is given after the second shock, then repeated every 3 to 5 minutes during resuscitation. Adenosine and atropine are not indicated for pulseless VF, and magnesium is not a routine drug for undifferentiated VF unless there is a specific indication, such as torsades de pointes. Question number 22. A patient in cardiac arrest has an advanced airway placed during CPR. Which finding is the most reliable immediate method to confirm and monitor correct tube placement during ACLS? A. Equal breath sounds alone. B. Visible chest rise alone. C. Quantitative waveform capnography. D. Improvement in skin color. Correct answer, C. Quantitative waveform capnography. Let's see its explanation. The 2025 AHA Adult Cardiac Arrest algorithm continues to recommend quantitative waveform capnography to confirm and monitor endotracheal tube placement. Breath sounds and chest rise help, but waveform capnography is the most reliable immediate ongoing confirmation method in ACLS. Question number 23. A 59-year-old patient presents with palpitations. HR is 178 per minute. BP 118/72 millimeters Hg, SpO2 97%, and the rhythm is regular, wide complex monomorphic tachycardia. He is alert and denies chest pain. What is the best next step? A. Immediate unsynchronized defibrillation. B. Synchronized cardioversion. C. Consider adenosine only if the rhythm is regular and monomorphic. D. atropine 1 mg IV. Correct answer, C. Consider adenosine only if the rhythm is regular and monomorphic. So what about its explanation? For stable, regular, monomorphic wide QRS tachycardia, the 2025 tachyarrhythmia algorithm allows adenosine as a consideration if the rhythm is regular and monomorphic. Antiarrhythmic infusion is also an option, while immediate shock is reserved for instability or deterioration. Question number 24. A patient with tachycardia has a heart rate of 190 per minute. He is diaphoretic, confused, and his blood pressure is 78/46 millimeters Hg. The rhythm is organized and there is a pulse. What is the priority intervention? A. Vagal maneuvers followed by observation. B. Synchronized cardioversion. C. Epinephrine 1 mg IV push. D. Delay treatment until a 12-lead ECG is completed. Correct answer, B. Synchronized cardioversion. Now let's see its explanation. In the 2025 AHA tachyarrhythmia algorithm, hypotension, altered mental status, shock, ischemic chest discomfort, or acute heart failure indicate instability and require immediate synchronized cardioversion. Question number 25. A patient achieves ROSC after prolonged resuscitation. He remains hypotensive despite fluid bolus. Which vasoactive infusion is listed in the 2025 adult cardiac arrest/post-cardiac arrest algorithm as an appropriate option to support blood pressure? A. Dopamine infusion. B. Adenosine infusion. C. Verapamil infusion. D. Lidocaine infusion only. Correct answer, A. Dopamine infusion. Let's see its explanation. In post-cardiac arrest care after ROSC, the algorithm includes vasopressor support for hypotension, such as epinephrine infusion, norepinephrine infusion, or dopamine infusion alongside fluids and treatment of the underlying cause. Question number 26. A 71-year-old patient has sinus bradycardia at 32 per minute with dizziness, hypotension, and cool, clammy skin. IV access is present. What is the correct initial atropine dose per the 2025 bradycardia algorithm? A. 0.5 milligrams IV. B. 1 milligram IV. C. 2 milligrams IV. D. 3 milligrams IV. Correct answer, B. 1 milligram IV. So what about its explanation? The 2025 AHA adult bradycardia algorithm recommends atropine 1 milligram IV, repeated every 3 to 5 minutes to a maximum total dose of 3 milligrams for symptomatic bradycardia. Question number 27. A patient is in PEA arrest. The team has completed several high-quality CPR cycles. Epinephrine has been given and no pulse is present. Which next action best reflects the ACLS algorithm? A. Defibrillate immediately because all arrests eventually need a shock. B. Focus on identifying and treating reversible causes. C. Give atropine because PEA often represents vagal excess. D. Administer routine calcium and sodium bicarbonate. Correct answer, B. Focus on identifying and treating reversible causes. Well, let's see its explanation. In PEA/asystole, defibrillation is not indicated unless the rhythm becomes shockable. The algorithm emphasizes continued CPR, epinephrine every 3 to 5 minutes, and active search for reversible causes, H's and T's. Routine calcium and sodium bicarbonate are not recommended in undifferentiated arrest. Question number 28. A patient with symptomatic bradycardia remains unstable after atropine. Transcutaneous pacing is not immediately available. What is the most appropriate pharmacologic bridge? A. Epinephrine infusion or dopamine infusion. B. Adenosine rapid IV push. C. Amiodarone 300 milligrams IV push. D. Magnesium sulfate routine infusion. Correct answer, A. Epinephrine infusion or dopamine infusion. Let's see its explanation. When atropine is ineffective in symptomatic bradycardia, the 2025 AHA algorithm recommends transcutaneous pacing and/or epinephrine infusion or dopamine infusion as next-line therapy. Question number 29. During a prolonged resuscitation, an endotracheal tube is successfully placed. Chest compressions continue without interruption. How should ventilation now be delivered? A. 2 breaths after every 30 compressions. B. 1 breath every 6 seconds. C. 1 breath every 10 seconds. D. 8 breaths followed by a rhythm check. Correct answer, B. 1 breath every 6 seconds. So what about its explanation? Once an advanced airway is in place during adult cardiac arrest, the algorithm recommends continuous compressions with 1 breath every 6 seconds, which equals 10 breaths per minute. Question number 30. During an arrest, a new team member asks whether to give steroids, calcium, sodium bicarbonate, and magnesium routinely to improve outcomes. What's the best response? A. Yes, they should be given in all adult cardiac arrests. B. Only calcium should be given routinely. C. These are not recommended routinely in undifferentiated adult cardiac arrest. D. Give them only before the first shock. Correct answer, C. These are not recommended routinely in undifferentiated adult cardiac arrest. So let's see its explanation. The 2025 Adult Advanced Life Support Update advises against routine use of steroids, calcium, sodium bicarbonate, and magnesium in undifferentiated adult cardiac arrest. These drugs may still have specific indication-based uses, such as torsades or hyperkalemia, but not as routine arrest medications. Question number 41. A 56-year-old man collapses in the telemetry unit. He is unresponsive, apneic, and pulseless. The monitor shows VF. Your team starts high-quality CPR, provides oxygen, and delivers the first shock. After 2 minutes of CPR, the rhythm remains VF and a second shock is delivered. IV access is already in place. What is the best next action? A. Give amiodarone 300 milligrams IV immediately before resuming CPR. B. Check for a pulse for 15 seconds. C. Resume CPR and give epinephrine 1 milligram IV IO. D. Insert an advanced airway before continuing compressions. Correct answer, C. Resume CPR and give epinephrine 1 milligram IV IO. Now let's see its explanation. In the adult VF-PVT cardiac arrest algorithm, after the second shock, the next steps are immediate CPR plus epinephrine 1 milligram IV IO, repeated every 3 to 5 minutes. Amiodarone or lidocaine is considered later for refractory shockable arrest. Pulse checks should be brief and only during rhythm checks, not prolonged after a shock. Question number 42. During the same code, after another CPR cycle, the monitor now shows an organized rhythm at 70 per minute. The patient is still unresponsive and no pulse is felt within the pulse check window. End-tidal CO2 remains low. What should the team do next? A. Declare ROSC because an organized rhythm is present. B. Resume CPR and manage as PEA. C. Defibrillate immediately. D. Start atropine because the rhythm is slow. Correct answer, B. Resume CPR and manage as PEA. Let's see its explanation. An organized rhythm without a pulse is PEA, not ROSC. The correct action is to resume CPR immediately, continue epinephrine every 3 to 5 minutes, and search for reversible causes. Defibrillation is not indicated unless the rhythm becomes shockable. Question number 43. A patient in cardiac arrest is intubated during ongoing ACLS. Breath sounds seem present, but the team leader wants the most reliable immediate method to confirm and then continuously monitor tube placement during the resuscitation. Which is best? A. Chest rise alone. B. Fogging in the tube. C. Quantitative waveform capnography. D. Pulse oximetry. Correct answer, C. Quantitative waveform capnography. Now let's see its explanation. In the adult cardiac arrest algorithm, the AHA adult cardiac arrest algorithm recommends continuous waveform capnography for confirmation and ongoing monitoring of advanced airway placement during ACLS. Pulse oximetry is not reliable for immediate tube confirmation during arrest. Question number 44. A 69-year-old patient develops palpitations and diaphoresis after an acute MI. HRA is 188 per minute. BP is 76/40 millimeters mercury. He is confused, and the monitor shows a regular wide complex tachycardia with a pulse. IV access is present. What is the priority treatment? A. Adenosine rapid IV push because the rhythm is regular. B. Synchronized cardioversion. C. Amiodarone infusion over 10 minutes first. D. Observe while obtaining a 12-lead ECG. Correct answer, B. Synchronized cardioversion. So what about its explanation? In the adult tachycardia arrhythmia algorithm, hypotension and altered mental status indicate unstable tachycardia, which requires immediate synchronized cardioversion. Adenosine can be considered in stable, regular, monomorphic wide complex rhythms, but instability makes cardioversion the priority. Question number 45. A 61-year-old patient is alert, speaking clearly, and has BP 124/78 millimeters mercury. He has a regular monomorphic wide complex tachycardia at 172 per minute. No chest pain, no shock, no altered mentation. Which option is most appropriate? A. Immediate unsynchronized defibrillation. B. Consider adenosine because the rhythm is regular and monomorphic. C. Atropine 1 mg IV. D. Epinephrine 1 mg IV push. Correct answer, B. Consider adenosine because the rhythm is regular and monomorphic. Now let's see its explanation. In stable, regular, monomorphic wide QRS tachycardia, adenosine may be considered, and anti-arrhythmic infusion is also an option. Defibrillation is for pulseless rhythms or unstable polymorphic VT. Question number 46. A 75-year-old dialysis patient becomes pale and diaphoretic. HR is 28 per minute, BP 72/38 millimeters mercury, and he is increasingly confused. Oxygen is applied and IV access is established. You give atropine 1 mg IV, but there is no improvement. Pacing pads are being placed, but setup is delayed. What is the best next medication strategy? A. Adenosine 6 mg rapid IV push. B. Epinephrine infusion or dopamine infusion. C. Amiodarone 150 mg IV over 10 minutes. D. Routine sodium bicarbonate and calcium for all bradycardia. Correct answer, B. Epinephrine infusion or dopamine infusion. Now let's see its explanation. For stable symptomatic bradycardia unresponsive to atropine, the 2025 bradycardia algorithm recommends transcutaneous pacing and/or epinephrine infusion or dopamine infusion. Because this patient is a dialysis patient, reversible causes such as hyperkalemia should also be considered and treated specifically if present. Question number 47. A patient with unstable monomorphic VT with a pulse requires synchronized cardioversion. According to the 2025 AHA electrical cardioversion algorithm, what initial energy is listed? A. 50 joules, B. 100 joules, C. 200 joules, D. Unsynchronized high-energy shock only. Correct answer, B. 100 joules. So what about its explanation? The 2025 AHA electrical cardioversion algorithm lists 100 joules for monomorphic VT, 100 joules for narrow complex tachycardia, and 200 joules for atrial fibrillation or atrial flutter. Polymorphic VT is treated with unsynchronized high-energy shock, defibrillation, rather than synchronized cardioversion. Question number 48. A patient achieves ROSC after PEA arrest. He remains intubated and requires ICU transfer. Which post-cardiac arrest target is specifically included in the 2025 AHA post-cardiac arrest care algorithm? A. Target MAP below 60 mm mercury to avoid bleeding. B. Target MAP at least 65 mm mercury. C. Maintain glucose above 250 mg per deciliter. D. Maintain PaO2 above 200 mm mercury in all patients. Correct answer, B. Target MAP at least 65 mmHg. Now let's see its explanation. The 2025 post-cardiac arrest care algorithm includes ongoing critical care targets, such as MAP greater than 65, PaO2 60 to 105, PCO2 35 to 45, unless severe acidemia is present, and avoidance of both hypoglycemia and marked hyperglycemia. Question number 49. A patient in prolonged resuscitation has an advanced airway in place. The compressor is performing continuous compressions. Which ventilation strategy is correct? A. 30 compressions to 2 breaths. B. 1 breath every 6 seconds with continuous compressions. C. 1 breath every 10 seconds with pauses every minute. D. 2 breaths after each shock. Correct answer, B. 1 breath every 6 seconds with continuous compressions. So what about its explanation? Once an advanced airway is placed during adult cardiac arrest, the AHA algorithm recommends continuous chest compressions and 1 breath every 6 seconds or 10 breaths per minute. Question number 50. During a prolonged undifferentiated PEA arrest, a team member recommends giving calcium, magnesium, sodium bicarbonate, and steroids because it has been a long code. What is the best response by the team leader? A. Give all 4 routinely in prolonged arrest. B. Give magnesium and calcium routinely, but not sodium bicarbonate. C. These are not recommended routinely in undifferentiated adult cardiac arrest. D. Give them only after the next shock. Correct answer, C. These are not recommended routinely in undifferentiated adult cardiac arrest. Let's see its explanation. The 2025 AHA Adult Advanced Life Support Guidance advises against routine administration of calcium, magnesium, sodium bicarbonate, and steroids in undifferentiated adult cardiac arrest. These agents may still have specific indication-based roles, such as torsades or certain toxicologic or metabolic causes, but not as routine Megacode drugs. Question number 51. A patient in cardiac arrest receives defibrillation for VF. At the next rhythm check, the monitor shows an organized rhythm at 82 per minute. The patient remains unresponsive and no pulse is definitely felt within 10 seconds. What is the best next action? A. Start post-ROSC care because the rhythm is organized. B. Resume CPR and treat as PEA. C. Give atropine 1 mg IV. D. Perform synchronized cardioversion. Correct answer, B. Resume CPR and treat as PEA. Let's see its explanation. The trap is assuming that an organized rhythm equals ROSC. It does not. If there is no pulse, the patient has PEA, and the correct action is to resume CPR immediately, continue epinephrine every 3 to 5 minutes, and search for reversible causes. Organized rhythm without a pulse is not post-ROSC care. Question number 52. A patient is in pulseless VT. After the first shock, CPR is resumed. The rhythm is still pulseless VT after 2 minutes, and a second shock is delivered. IV access is available. What is the most appropriate next step? A. Resume CPR and give epinephrine 1 mg IV. B. Give amiodarone 300 mg IV before restarting compressions. C. Pause to check for a pulse for 15 seconds. D. Insert an advanced airway before any medication. So let's see its correct answer. A. Resume CPR and give epinephrine 1 mg IV. Explanation. The trap here is choosing amiodarone too early. In the shockable arrest sequence, epinephrine generally follows the second shock, while amiodarone or lidocaine is considered later for refractory VF, pulseless VT. CPR should resume immediately after the shock. Question number 53. A patient has a regular monomorphic wide complex tachycardia at 170 per minute. BP is 122/74 millimeters of Hg. Mentation is normal, and there is no chest pain or heart failure. Which option is most appropriate? A. Immediate unsynchronized defibrillation. B. Immediate synchronized cardioversion because all wide tachycardias are unstable. C. Consider adenosine because the rhythm is regular and monomorphic. D. Atropine 1 mg IV because the rhythm may deteriorate. Correct answer, C. Consider adenosine. Now let's see its explanation. The trap is overreacting to the wide QRS. If the patient is stable and the rhythm is regular monomorphic wide complex tachycardia, adenosine may be considered. Shocking is reserved for instability or pulselessness, and atropine is not indicated. The AHA algorithm also supports antiarrhythmic infusion in stable wide complex tachycardia. Question number 54. A patient with tachycardia has HR 168 per minute, BP 84/52 millimeters of Hg, diaphoresis, and confusion. The monitor shows an organized rhythm and a pulse is present. Which action is best? A. Obtain a 12-lead ECG before treatment. B. Give adenosine because the patient has a pulse. C. Perform synchronized cardioversion. D. Defibrillate immediately. Correct answer, C. Perform synchronized cardioversion. So what about its explanation? The trap is delaying treatment for more diagnostics or choosing adenosine simply because a pulse is present. Hypotension and altered mental status indicate unstable tachyarrhythmia, and the priority treatment is synchronized cardioversion. Defibrillation is used for pulseless rhythms or polymorphic VF or VT. Question number 55. You are preparing to cardiovert unstable monomorphic VT with a pulse. According to the 2025 AHA electrical cardioversion algorithm, what initial energy is listed? A. 50 joules, B. 100 joules, C. 200 joules, D. Unsynchronized high-energy shock. Correct answer, B. 100 joules. Let's see its explanation. The trap is mixing cardioversion energies across rhythms. The 2025 AHA electrical cardioversion algorithm lists 100 joules for monomorphic VT, 100 joules for narrow complex tachycardia, and 200 joules for atrial fibrillation or atrial flutter. Polymorphic VT is treated with unsynchronized high-energy shock, not synchronized cardioversion. Question number 56. A 70-year-old patient has symptomatic sinus bradycardia at 30 per minute with hypotension and dizziness. What is the correct initial atropine dose? A. 0.5 milligrams IV, B. 1 milligram IV, C. 2 milligrams IV, D. 3 milligrams IV. Correct answer, B. 1 milligram IV. Now let's see its explanation. The trap is remembering the older atropine dose. In the current adult bradycardia algorithm, the initial dose is atropine 1 milligram IV, repeated every 3 to 5 minutes to a maximum total of 3 milligrams. Question number 57. A patient remains unstable with symptomatic bradycardia after atropine. Transcutaneous pacing is being arranged, but there will be a delay. Which is the best next pharmacologic bridge? A. Adenosine rapid IV push, B. Epinephrine infusion or dopamine infusion, C. Amiodarone 150 milligrams IV, D. Routine calcium bolus for all refractory bradycardia. Correct answer, B. Epinephrine infusion or dopamine infusion. Let's see the explanation. The trap is choosing a rhythm that does not fit the problem. When atropine is ineffective, the algorithm supports transcutaneous pacing and/or epinephrine infusion or dopamine infusion. Adenosine and amiodarone are not bradycardia rescue drugs, and calcium is not routine unless there is a specific cause, such as hyperkalemia. Question number 58. A patient in cardiac arrest has been intubated successfully. Chest compressions are continuous. Which ventilation approach is correct now? A. 30 to 2. B. 1 breath every 3 seconds. C. 1 breath every 6 seconds. D. 2 breaths after every rhythm check. Correct answer, C. 1 breath every 6 seconds. So what about its explanation? The trap is keeping the pre-airway ventilation ratio. Once an advanced airway is in place, adult cardiac arrest care changes to continuous compressions with 1 breath every 6 seconds, or about 10 breaths per minute. Question number 59. During prolonged undifferentiated PEA arrest, a team member suggests giving magnesium, calcium, sodium bicarbonate, and steroids because the code has been going on for a long time. What is the best response? A. Give all 4 routinely in prolonged arrest. B. Give calcium and bicarbonate routinely, but not magnesium or steroids. C. These are not recommended routinely in undifferentiated adult cardiac arrest. D. Give them only after epinephrine fails twice. Correct answer, C. These are not recommended routinely in undifferentiated adult cardiac arrest. Let's see its explanation. The trap is assuming that a longer arrest justifies empiric drug stacking. The 2025 AHA Adult Advanced Life Support Guidance says routine administration of calcium, sodium bicarbonate, and magnesium is not recommended, and steroids are of uncertain benefit rather than standard routine therapy. Specific indications still matter, such as torsades, hyperkalemia, or toxicologic causes. Question number 60. A patient achieves ROSC after cardiac arrest and is admitted to the ICU. Which post-cardiac arrest hemodynamic target is included in the 2025 AHA post-cardiac arrest care algorithm? A. MAP less than 60 mm Hg. B. MAP at least 65 mm Hg. C. PaO2 above 200 mm Hg for all patients. D. PCO2 below 25 mm Hg routinely. Correct answer, B. MAP at least 65 mm Hg. Now let's see its explanation. The trap is overcorrecting physiology. The 2025 post-cardiac arrest care algorithm includes MAP greater than 65 mm Hg and recommends avoiding extremes of oxygenation and ventilation rather than aiming for universal hyperoxia or hypocapnia. Question number 61. A 57-year-old man collapses in the CCU. He is unresponsive, apneic, and pulseless. The monitor shows VF. High-quality CPR is started and a biphasic shock is delivered. After 2 minutes, VF persists and a second shock is given. IV access is already present. Which sequence is most appropriate next? A. Check pulse, give amiodarone 300 mg IV, resume CPR. B. Resume CPR, give epinephrine 1 mg IV/IO, consider advanced airway, capnography. C. Intubate first, check rhythm again, give epinephrine if still VF. D. Resume CPR, give atropine 1 mg IV, prepare synchronized cardioversion. Correct answer is B. Resume CPR, give epinephrine 1 mg IV/IO, consider advanced airway, capnography. Let's see its explanation. In the 2025 adult VF/PVT arrest algorithm, after the second shock, the next sequence is immediate CPR, epinephrine 1 mg IV/IO, then continued cycles with advanced airway and capnography consideration as appropriate. Pulse checks should not delay CPR. Atropine is not used for VF, and synchronized cardioversion is not used in pulseless shockable arrest. Question number 62. During the same code after another CPR cycle, the monitor now shows an organized rhythm at 74 per minute. The patient remains unresponsive, and no definite pulse is felt within 10 seconds. Which sequence is best? A. Begin post-ROSC care. Obtain 12-lead ECG. Start vasopressor. B. Resume CPR. Treat as PEA. Continue epinephrine every 3 to 5 minutes and search for reversible causes, H's and T's. C. Give atropine 1 mg IV. Start pacing pads. Reassess in 2 minutes. D. Defibrillate immediately. Resume CPR if rhythm persists. Correct answer is B. Resume CPR, treat as PEA, continue epinephrine every 3 to 5 minutes, and actively search and treat reversible causes, H's and T's. Now, let's see its explanation. An organized rhythm without a pulse is PEA, not ROSC. The correct sequence is resume CPR immediately, give epinephrine every 3 to 5 minutes, and actively search for and treat reversible causes, H's and T's. Defibrillation is not indicated unless the rhythm becomes shockable. Question number 63. A 68-year-old patient develops palpitations and chest pressure. HR is 186 per minute. BP is 78 by 44 millimeters mercury, and he is confused. The monitor shows a regular monomorphic wide complex tachycardia with a pulse. Which sequence is most appropriate? A. Adenosine 6 mg rapid IV push, flush, reassess. B. Synchronized cardioversion, use device recommended energy or maximum if unknown. C. Defibrillate, give epinephrine 1 mg IV, give amiodarone. D. Obtain 12-lead ECG, consider procainamide if QRS remains wide. Correct answer is B. Synchronized cardioversion, use device recommended energy or maximum if unknown. So what about its explanation? In unstable tachyarrhythmia with a pulse, the priority is immediate synchronized cardioversion. The 2025 AHA Tachyarrhythmia Guidance says to use the device's recommended energy and, if not known, the maximum available energy. Adenosine may be considered in certain stable, regular monomorphic wide QRS cases, but not when the patient is unstable. Question number 64. A 61-year-old patient is alert, speaking full sentences. BP is 126 by 80 millimeters mercury and has regular monomorphic wide complex tachycardia at 172 per minute. No chest pain, no hypotension, no acute heart failure. Which sequence is best? A. Immediate synchronized cardioversion, sedation after shock. B. Consider adenosine if regular and monomorphic. Consider antiarrhythmic infusion if needed. C. Defibrillate, resume CPR if rhythm persists. D. Atropine 1 mg IV, transcutaneous pacing if ineffective. Correct answer is B. Consider adenosine if regular and monomorphic. Consider antiarrhythmic infusion if needed. Now, let's see its explanation. For stable, regular, monomorphic wide QRS tachycardia, the 2025 AHA algorithm allows adenosine consideration and also supports antiarrhythmic infusion such as procainamide, amiodarone, or sotalol, depending on the case. Shocking is reserved for instability or pulselessness.
Question number 65. A 72-year-old patient becomes pale, dizzy, and diaphoretic. HR is 30 per minute, BP 76/40 millimeters per mercury, and mentation is worsening. Oxygen is started, monitor attached, IV access confirmed. Which sequence best matches the 2025 algorithm? A. Atropine 1 mg IV, if ineffective, transcutaneous pacing and/or dopamine or epinephrine infusion. B. Adenosine 6 mg IV, repeat 12 mg, pacing if no improvement. C. Defibrillation, CPR, epinephrine 1 mg every 3 to 5 minutes. D. Synchronized cardioversion, amiodarone infusion. Correct answer, A. Atropine 1 mg IV, if ineffective, transcutaneous pacing and/or dopamine or epinephrine infusion. So let's see its explanation.
In symptomatic adult bradycardia with poor perfusion, the 2025 algorithm recommends atropine 1 mg IV first, then transcutaneous pacing and/or dopamine infusion or epinephrine infusion if atropine is ineffective. Adenosine and cardioversion are not bradycardia treatments. Question number 66. A patient in cardiac arrest is intubated successfully during ongoing ACLS. The compressor is doing continuous compressions. Which sequence is correct after advanced airway placement? A. Continue 32 compressions and breaths. Rhythm check every minute. B. Continuous compressions, 1 breath every 6 seconds. Use waveform capnography. C. Pause compressions for 2 breaths every 30 seconds. Confirm with pulse oximetry. D. Ventilate every 3 seconds. Rotate compressor every 5 minutes. Correct answer? B. Continuous compressions, 1 breath every 6 seconds. Use waveform capnography. Now let's see its explanation. Once an advanced airway is placed, adult cardiac arrest care changes to continuous chest compressions with 1 breath every 6 seconds, 10 per minute. The AHA algorithm also emphasizes continuous waveform capnography for airway confirmation and monitoring, and CPR quality assessment. Question number 67. A patient remains in VF after 2 shocks, CPR, and epinephrine. A 3rd shock is delivered and CPR resumes. Which sequence is now most appropriate? A. Amiodarone or lidocaine continue CPR, treat reversible causes. B. Atropine 1 mg IV, pacing pads, rhythm check. C. Adenosine 6 mg IV, flush, synchronized cardioversion. D. Sodium bicarbonate, calcium, magnesium, and steroids routinely. Correct answer? A. Amiodarone or lidocaine continue CPR, treat reversible causes. Let's see its explanation. In refractory VF or VT after additional shocks and epinephrine, the 2025 algorithm says to consider amiodarone or lidocaine, continue CPR, and treat reversible causes. Routine empiric use of bicarbonate, calcium, magnesium, or steroids is not recommended in undifferentiated arrest.
Question number 68. A patient achieves ROSCO after PEA arrest. He remains intubated. BP is 82/46 millimeters of mercury after initial fluids. Glucose is 210 milligrams per deciliter, and oxygen saturation is 100% on very high FiO2. Which sequence best fits 2025 post-cardiac arrest care priorities? A. Target MAP greater than 65 millimeters of mercury. Avoid hypoglycemia and marked hyperglycemia. Target PaO2 60 to 105 millimeters of mercury and PCO2 35 to 45 millimeters of mercury unless severe acidemia is present, and avoidance of both hypoglycemia and marked hyperglycemia. B. Keep MAP less than 60 millimeters of mercury. Maintain hyperoxia. Lower PCO2 below 25 millimeters of mercury. C. Stop active management because ROSCO is achieved. D. Give routine bicarbonate and calcium before ICU transfer. Correct answer is A. Target MAP greater than 65 millimeters of mercury. Avoid hypoglycemia and marked hyperglycemia. Target PaO2 60 to 105 millimeters of mercury and PCO2 35 to 45 millimeters of mercury unless severe acidemia is present, and avoidance of both hypoglycemia and marked hyperglycemia. So what about its explanation? The 2025 post-cardiac arrest care algorithm includes MAP greater than 65 millimeters of mercury, PaO2 60 to 105 millimeters of mercury, PCO2
35 to 45 millimeters of mercury unless severe acidemia is present, and avoidance of both hypoglycemia and marked hyperglycemia.
Question number 69.
A patient with a pulse has unstable monomorphic VT and requires synchronized cardioversion. Which sequence is correct based on the 2025 electrical cardioversion algorithm? A. Unsynchronized high-energy shock because all VT gets defibrillated. B. Synchronized cardioversion at 100 joules for monomorphic VT. C. Synchronized cardioversion at 200 joules because that is the only listed dose. D. Adenosine first regardless of instability. Correct answer is B. Synchronized cardioversion at 100 joules for monomorphic VT. Now let's see its explanation. The 2025 electrical cardioversion algorithm lists 100 joules for monomorphic VT. It also lists 100 joules for narrow complex tachycardia and 200 joules for atrial fibrillation or atrial flutter. Polymorphic VT is treated with unsynchronized high-energy shock, not synchronized cardioversion. Question number 70. During a prolonged, undifferentiated PEA arrest, a new team member proposes, let's give calcium, magnesium, sodium bicarbonate, and steroids now because the code is long. Which sequence is most appropriate? A. Give all 4 drugs routinely, then resume CPR. B. Continue CPR and epinephrine as indicated, search for specific reversible causes, use non-routine drugs only for clear indications. C. Stop CPR and obtain a 12-lead ECG before any further therapy. D. Replace epinephrine with atropine because PEA is non-shockable. Correct answer is B. Continue CPR and epinephrine as indicated, search for specific reversible causes, and use non-routine drugs only for clear indications. Now let's see its explanation. In undifferentiated adult cardiac arrest, the 2025 AHA guidance does not recommend routine use of calcium, magnesium, sodium bicarbonate, or steroids. The correct sequence is ongoing high-quality CPR, epinephrine for non-shockable arrest, and an aggressive search for reversible causes, with indication-based drug use only when clinically justified.
Question 71. A 79-year-old man presents with repeated near syncope, fatigue, and hypotension. The monitor strip below shows more P waves than QRS complexes, with no fixed relationship between atrial and ventricular activity. Which ECG rhythm is most likely? See this ECG and answer this question. A. Sinus bradycardia. B. Second-degree AV block type 1. C. Complete heart block, third-degree AV block. D. Junctional rhythm. Correct answer, C. Complete heart block, third-degree AV block. Let's see its explanation. The strip shows AV dissociation. Regular P waves march through independently while a slower escape rhythm generates the QRS complexes. That pattern is classic for complete heart block. In ACLS, symptomatic high-grade block with poor perfusion often requires prompt pacing while definitive care is arranged.
Question number 72. A 68-year-old post-operative patient develops sudden palpitations. She is alert, but her monitor shows a very regular, narrow complex tachycardia close to 150 per minute. Careful inspection reveals repetitive atrial activity between QRS complexes. Which rhythm is most likely? See this ECG and answer this question. A. Sinus tachycardia. B. Atrial flutter with 2-to-1 AV conduction. C. Atrial fibrillation with rapid ventricular response. D. AV nodal reentrance tachycardia. Correct answer, B. Atrial flutter with 2-to-1 AV conduction. Now let's see its explanation. A ventricular rate near 150 per minute with a very regular rhythm should always raise suspicion for atrial flutter with 2-to-1 conduction. The atrial waves create a sawtooth baseline between QRS complexes. The trap is mistaking it for simple sinus tachycardia or generic SVT. Question number 73. A 64-year-old patient with prior myocardial infarction reports chest pressure, diaphoresis, and dizziness. The strip shows a regular, fast, wide, complex rhythm without clear preceding P waves. Which ECG rhythm is most likely? See this ECG and answer this question. A. SVT with aberrancy. B. Monomorphic ventricular tachycardia. C. Atrial flutter with aberrant conduction. D. Accelerated idioventricular rhythm. Correct answer, B. Monomorphic ventricular tachycardia. So what about its explanation? A regular wide complex tachycardia in a patient with structural heart disease should be presumed ventricular tachycardia until proven otherwise. The broad uniform QRS morphology and fast rate support monomorphic VT. In ACLS, instability with a pulse would point towards synchronized cardioversion. Question number 74. A 52-year-old woman receiving a QT prolonging medication becomes briefly unresponsive. The monitor shows a rapid polymorphic wide complex tachycardia with waxing and waning amplitude that appears to twist around the baseline. Which rhythm is most likely? See this ECG and answer this question. A. Monomorphic ventricular tachycardia. B. Torsades de pointes. C. Ventricular fibrillation. D. Atria flutter with variable block. Correct answer, B. Torsades de pointes. Let's see its explanation. The polymorphic QRS complexes change amplitude and axis, producing the classic twisting appearance of torsades de pointes. The trap is confusing it with monomorphic VT or coarse VF. In ACLS, torsades is treated as a shockable rhythm if pulseless, and magnesium is used when clinically indicated.
Question 75. A 70-year-old patient complains of lightheadedness. On the rhythm strip, the PR interval gradually lengthens until a P wave is not followed by a QRS complex, after which the cycle repeats. Which ECG rhythm is most likely? See this ECG and answer this question. A. First-degree AV block. B. Second-degree AV block type 1 Wenckebach. C. Second-degree AV block type 2. D. Complete heart block. Correct answer, B. Second-degree AV block type 1 Wenckebach. Now let's see its explanation. The hallmark of Wenckebach is progressive PR prolongation followed by a dropped QRS complex. The grouped beating pattern helps distinguish it from Mobitz 2, where PR intervals are fixed before the dropped beat. Question number 76. A 73-year-old man with anterior ischemia becomes dizzy. His strip shows regular P waves, intermittent non-conducted P waves, and constant PR intervals on conducted beats. Which rhythm is most likely? See this ECG and answer this question. A. Second-degree AV block type 1. B. Second-degree AV block type 2. C. Junctional escape rhythm. D. Complete heart block. Correct answer, B. Second-degree AV block type 2. What about its explanation? Mobitz 2 shows sudden dropped QRS complexes without progressive PR prolongation. Conducted beats have a fixed PR interval. This is a higher risk conduction disturbance than Wenckebach and can deteriorate into complete heart block. Question number 77. A 61-year-old patient taking AV nodal blocking medication has fatigue and mild dizziness. The strip shows a regular marrow complex rhythm at a slow rate and retrograde or absent P waves, rather than normal sinus P waves before each QRS. Which rhythm is most likely? See this ECG and answer this question. A. Sinus bradycardia. B. Junctional rhythm. C. First-degree AV block. D. Idioventricular rhythm. Correct answer, B. Junctional rhythm. Let's see its explanation. A junctional rhythm is typically regular, narrow complex, and slow with absent, inverted, or retrograde P waves rather than upright sinus P waves preceding the QRS. The trap is calling any slow, narrow rhythm sinus bradycardia without checking the atrial activity carefully.
Question 78. A 76-year-old woman with heart failure reports dyspnea and palpitations. Her pulse is fast and irregularly irregular. The strip below shows an absence of organized P waves with variable R to R intervals. Which ECG rhythm is most likely? See this ECG and answer this question. A. Atrial flutter with variable block. B. Multifocal atrial tachycardia. C. Atrial fibrillation with rapid ventricular response. D. Sinus tachycardia with frequent PACs. Correct answer, C. Atrial fibrillation with rapid ventricular response. Now let's see its explanation. The rhythm is irregularly irregular and there are no consistent P waves. That combination strongly supports atrial fibrillation with rapid ventricular response. The trap is confusing it with multifocal atrial tachycardia, which has at least 3 distinct P wave morphologies. Question 79. A 58-year-old patient is being monitored after successful PCI for an inferior STEMI. He is hemodynamically stable, and the strip shows a regular wide complex rhythm slightly faster than a ventricular escape rhythm, but slower than typical VT. Which rhythm is most likely? See this ECG and answer this question. A. Monomorphic ventricular tachycardia. B. Accelerated idioventricular rhythm. C. Complete heart block with ventricular escape. D. Hyperkalemic sine wave rhythm. Correct answer? B. Accelerated idioventricular rhythm. Explanation? Accelerated idioventricular rhythm is a reperfusion-associated ventricular rhythm that is usually regular, wide complex, and slower than classic VT. The relatively modest rate and stable clinical context helps separate it from monomorphic VT. Question 80. A patient suddenly becomes pulseless and unresponsive in the coronary care unit. The rhythm strip shows chaotic, disorganized electrical activity with no identifiable P waves, QRS complexes, or T waves. Which ECG rhythm is most likely? See this ECG and answer this question. A. Torsades de pointes. B. Asystole. C. Ventricular fibrillation. D. Pulseless electrical activity. Correct answer? C. Ventricular fibrillation. So let's see its explanation. The strip shows chaotic irregular oscillations without organized complexes, which is consistent with ventricular fibrillation. It is coarse rather than fine because the waveform amplitude is still relatively large. In ACLS, VF is a shockable rhythm requiring immediate high-quality CPR and defibrillation.
Question number 81. A 68-year-old man presents with dizziness, fatigue, and near syncope. His blood pressure is 84/50 millimeters of mercury. He is pale but awake, and the monitor prints the rhythm strip shown below. Which ECG rhythm is most likely? See this ECG and answer this question. A. Normal sinus rhythm. B. Sinus bradycardia. C. Second-degree AV block type 2. D. Junctional rhythm. Correct answer, B.
sinus bradycardia. So let's see its explanation. The strip shows a regular rhythm with a visible P wave before every QRS complex, a constant PR relationship, narrow QRS complexes, and a slow ventricular rate. Those features are classic for sinus bradycardia. Question number 82. A 74-year-old woman reports sudden palpitations and mild shortness of breath after surgery. Her pulse is fast and irregular, and the nurse notes varying RR intervals on the monitor. Which ECG rhythm is most likely? See this ECG and answer this question. A. Atrial flutter with fixed block. B. Atrial fibrillation with rapid ventricular response. C. Multifocal atrial tachycardia. D. Sinus tachycardia. Correct answer, B. Atrial fibrillation with rapid ventricular response. Now let's see its explanation. This rhythm is irregularly irregular, lacks consistent organized P waves, and has narrow QRS complexes with a fast ventricular rate. Those findings strongly support atrial fibrillation with RVR. Question number 83. A 27-year-old patient suddenly develops a pounding heartbeat at work. He is anxious but alert, and his blood pressure is preserved. The monitor shows a very regular, narrow, complex tachycardia. Which rhythm best fits this strip? See this ECG and answer this question. A. Sinus tachycardia. B. Supraventricular tachycardia. C. Atrial fibrillation. D. Monomorphic ventricular tachycardia. Correct answer, B. Supraventricular tachycardia. Now let's see its explanation. The strip shows a very fast, regular, narrow, complex rhythm with no clearly visible normal sinus P waves before each QRS. That pattern is most consistent with SVT. Question number 84. A 61-year-old man with prior myocardial infarction develops sustained palpitations. He remains conscious, but the monitor shows a fast, regular rhythm with wide QRS complexes. Which ECG rhythm is most likely? See this ECG and answer this question. A. Supraventricular tachycardia with aberrancy. B. Monomorphic ventricular tachycardia. C. Torsades de pointes. D. Atrial flutter. Correct answer, B. Monomorphic ventricular tachycardia. So what about its explanation? The strip shows a regular, broad, complex tachycardia with a uniform QRS appearance from beat to beat. In an adult with structural heart disease, this should be considered monomorphic VT unless proven otherwise. Question number 85. A 59-year-old patient becomes unresponsive and pulseless in the coronary care unit. The defibrillator displays the rhythm strip below. Which rhythm is present? See this ECG and answer this question. A. Asystole. B. Pulseless electrical activity. C. Ventricular fibrillation. D. Monomorphic ventricular tachycardia. Correct answer is C. Ventricular fibrillation. So what about its explanation? The tracing is chaotic and disorganized without identifiable P waves, QRS complexes, or T waves. That appearance is classic for ventricular fibrillation, a shockable cardiac arrest rhythm. Question number 86. A 72-year-old patient collapses on the ward and is found pulseless. The monitor prints the strip below after leads are checked and confirmed. Which rhythm is most likely? See this ECG and answer this question. A. Fine ventricular fibrillation. B. Asystole. C. Pulseless ventricular tachycardia. D. Complete heart block. Correct answer is B. Asystole. So let's see its explanation. The strip shows an almost flat baseline without organized ventricular depolarization. After confirming leads and gain, this is most consistent with asystole, a non-shockable rhythm. Question number 87. A 35-year-old patient with a history of prolonged QT suddenly collapses and briefly loses consciousness. The monitor shows a rapid, polymorphic, wide complex rhythm that appears to twist around the baseline. Which rhythm is this? See this ECG and answer this question. A. Monomorphic ventricular tachycardia. B. Torsades de pointes. C. Supraventricular tachycardia. D. Ventricular fibrillation. Correct answer is B. Torsades de pointes. So let's see its explanation. The wide QRS complexes change amplitude and axis in a waxing and waning pattern that seems to rotate around the isoelectric line. That classic twisting appearance identifies torsades de pointes.
Question number 88. A 78-year-old man presents with weakness, confusion, and hypotension. The monitor shows slow ventricular complexes while atrial activity continues independently. Which rhythm is most likely? See this ECG and answer this question. A. Sinus bradycardia. B. Second-degree AV block type 1. C. Third-degree AV block. D. Junctional escape rhythm. Correct answer? C. Third-degree AV block. Now let's see its explanation. P waves are present but march through independently of the QRS complexes with no consistent PR interval. AV dissociation with a slow escape rhythm is diagnostic of complete or third-degree heart block. Question number 89. A patient in cardiac arrest has no pulse, but the monitor shows a very rapid, regular broad complex rhythm rather than chaotic fibrillation. Which rhythm is most likely? See this ECG and answer this question. A. Pulseless ventricular tachycardia. B. Ventricular fibrillation. C. Asystole. D. Atrial fibrillation with RVR. Correct answer? A. Pulseless ventricular tachycardia. Now, what about its explanation? The strip is regular. The QRS complexes are narrow, and each QRS is preceded by a sinus P wave. The rate is elevated, making this sinus tachycardia. Question number 90. A 24-year-old patient with fever and dehydration has palpitations but remains alert with normal blood pressure. The rhythm strip shows a fast, regular rhythm with visible P waves before each QRS. Which rhythm is most likely? See this ECG and answer this question. A. Sinus tachycardia. B. Supraventricular tachycardia. C. Atrial flutter. D. Junctional tachycardia. Correct answer? A. Sinus tachycardia. Now let's see its explanation. The strip is regular. The QRS complexes are narrow, and each QRS is preceded by a sinus P wave. The rate is elevated, making this sinus tachycardia. Question number 91. A 58-year-old man presents with mild fatigue after an episode of dehydration. He is awake, BP 124/78 mm Hg, pulse 64 per minute, and oxygen saturation 98% on room air. The monitor strip is shown below. He has no chest pain, no syncope, and no signs of poor perfusion. What is the best interpretation from this ECG strip? See this ECG and answer this question. A. First-degree AV block. B. Second-degree AV block Mobitz 1. C. Third-degree AV block. D. Normal sinus rhythm. Correct answer, A. First-degree AV block. So let's see its explanation. This strip shows first-degree AV block, identified by a prolonged but constant PR interval with 1-to-1 AV conduction. Because the patient is stable and not showing cardiopulmonary compromise, immediate ACLS electrical therapy is not indicated. The correct approach is monitoring, assessment for reversible causes, and escalation only if symptomatic bradycardia develops. Question number 92. A 67-year-old patient develops diaphoresis and lightheadedness after an inferior wall MI.
BP is 88/60 millimeters Hg, pulse 42 per minute, and the rhythm strip is shown below. He remains responsive but is clearly symptomatic. What is the best answer? See this ECG and answer this question. A. First-degree AV block. B. Second-degree AV block Mobitz 1. C. Third-degree AV block. D. Atrial flutter with slow response. Correct answer, B. Second-degree AV block Mobitz 1. Now, let's see its explanation. This is second-degree AV block Mobitz 1, Winkebeck, characterized by progressively lengthening PR intervals before a dropped QRS complex. Because the patient has hypotension and symptoms, this falls under the ACLS bradycardia pathway. Atropine 1 mg IV is the appropriate initial medication while monitoring for the need for pacing if the patient does not improve. Question number 93. A 72-year-old patient with an anterior MI becomes pale and dizzy. BP is 82/50 millimeters Hg and pulse 34 per minute, and the rhythm strip is shown below. Identify this ECG rhythm. A. Second-degree AV block Mobitz 1. B. Second-degree AV block Mobitz 2. C. Third-degree AV block. D. Sinus bradycardia. Correct answer, B. Second-degree AV block Mobitz 2. What about its explanation? This is second-degree AV block Mobitz 2. The hallmark is a constant PR interval in conducted beads with sudden dropped QRS complexes. In a symptomatic patient, Mobitz 2 is high risk and often requires urgent pacing rather than watchful waiting. ACLS management prioritizes transcutaneous pacing with vasoactive infusion support if needed, while definitive pacing is arranged. Question number 94. A 76-year-old patient is confused, hypotensive, and cool to touch. HR is 30 per minute, and BP is 70/40 millimeters Hg. The ECG strip below shows AV dissociation. Which ECG rhythm is best suits this scenario? See this ECG and answer this question. A. Third-degree AV block. B. Second-degree AV block Mobitz 1. C. Normal sinus rhythm. D. Pulseless electrical activity. Correct answer, A. Third-degree AV block. So what about its explanation? The rhythm is third-degree AV block, complete heart block, identified by independent atrial and ventricular activity with AV dissociation. In an unstable patient, pacing is the priority. Atropine may be attempted in symptomatic bradycardia, but complete heart block often requires immediate transcutaneous pacing and frequently a vasopressor bridge, while expert help or transvenous pacing is arranged. Question number 95. A 49-year-old patient reports chest pressure and anxiety after climbing stairs. BP is 138/84 millimeters Hg. Pulse is 84 per minute, and the strip below is obtained during monitoring. What is the best interpretation? See this ECG and answer this question. A. Normal sinus rhythm. B. Sinus tachycardia. C. Atrial fibrillation. D. PVCs. Correct answer, A. Normal sinus rhythm. Let's see its explanation. The strip shows normal sinus rhythm. ACLS treatment is driven by the patient's rhythm and hemodynamic status. A normal rhythm strip does not warrant antiarrhythmic therapy, pacing, or shock. The next step is continued assessment for other causes of chest pain or symptoms, rather than rhythm-directed resuscitation. Question number 96. A 63-year-old patient in a monitored bed complains of occasional skipped beats. BP is 126/80 millimeters Hg, oxygen saturation 97%, and he is alert. The strip below shows underlying sinus rhythm with intermittent premature wide beats. What is the best answer? See this ECG and answer this question. A. Premature ventricular complexes. B. Monomorphic ventricular tachycardia. C. Pacemaker rhythm. D. Third-degree AV block. Correct answer, A. Premature ventricular complexes. So the explanation is as follows. This rhythm shows premature ventricular complexes, which are early, wide ventricular beats interrupting an otherwise organized rhythm. In a stable patient, ACLS does not call for immediate defibrillation or cardioversion for isolated or intermittent PVCs. The priority is to evaluate the cause and monitor for deterioration or sustained ventricular arrhythmia. Question number 97. A 79-year-old patient is found unresponsive, not breathing normally, and pulseless. The monitor shows a very slow, dying ventricular rhythm like the strip below. Which option is best? A. Agonal rhythm. B. Stable idioventricular rhythm. C. Pulseless ventricular tachycardia. D. Pacemaker rhythm. Correct answer is A. Agonal rhythm. Now let's see its explanation. Agonal rhythm is a peri-arrest or arrest rhythm with extremely slow, ineffective ventricular activity and no meaningful perfusion. When the patient is pulseless, it is managed under the non-shockable cardiac arrest pathway, like severe PEA or asystole physiology, high-quality CPR, epinephrine every 3 to 5 minutes, and aggressive evaluation of reversible causes. Defibrillation is not indicated unless the rhythm becomes VF or PVT.
Question number 98. A 74-year-old patient with a permanent ventricular pacemaker is admitted for pneumonia. BP is 118 over 72 millimeters Hg, mentation is normal, and the rhythm strip below shows pacing spikes followed by wide-paced QRS complexes. What is the best answer? See this ECG and answer this question. A. Third-degree AV block. B. Pacemaker rhythm with capture. C. Ventricular fibrillation. D. PVCs only. Correct answer is B. Pacemaker rhythm with capture. Now, let's see its explanation. This is a paced rhythm with visible pacing spikes followed by captured ventricular complexes. In a stable patient with appropriate capture and no evidence of instability, no immediate ACLS intervention is required for the rhythm itself. Ongoing treatment should focus on the patient's presenting illness while continued monitoring confirms pacemaker function. Question number 99. A 68-year-old patient reports dizziness and near syncope. BP is 84 over 54 millimeters Hg. Pulse 38 per minute, and the strip below shows a slow sinus rhythm with a P wave before each QRS. Which option best suits? See this ECG and answer this question. A. Sinus bradycardia with symptoms. B. First-degree AV block. C. Normal sinus rhythm. D. Pulseless electrical activity. Correct answer is A. Sinus bradycardia with symptoms. Now what about the explanation? This is sinus bradycardia with cardiopulmonary compromise. The 2025 ACLS adult bradycardia pathway uses atropine 1 milligram IV as the initial medication, repeated every 3 to 5 minutes to a maximum total dose of 3 milligrams if needed. If ineffective, transcutaneous pacing and/or epinephrine or dopamine infusion should be considered. Question number 100. A patient in the ICU suddenly becomes unresponsive and pulseless. The monitor strip below is confirmed in 2 leads. Which answer is best? See this ECG and answer this question. A. Agonal rhythm. B. Asystole. C. Fine ventricular fibrillation. D. Stable paced rhythm. Correct answer is B. Asystole. Now let's see its explanation. This is asystole, a non-shockable cardiac arrest rhythm.
ACLS priorities are immediate high-quality CPR, epinephrine as soon as possible, and then every 3 to 5 minutes, airway oxygenation support, and treatment of reversible causes. Defibrillation is not indicated for true asystole.
If you made it through these scenarios, you're already sharpening the skills that save lives. But mastery comes from repetition, so don't stop here. Review the algorithms, challenge yourself with more cases, and keep training until every step becomes instinct. If you want more ACLS practice tests, rapid-fire scenarios, and exam-ready breakdowns, hit subscribe, turn on notifications, and keep building your clinical edge. Your next code starts now.